Dear ladies, dear gentlemen, I warmly welcome all of you to this very special medical online hub. As usual, we strive to exchange on interesting and valuable topics presented by passionate, renowned and knowledgeable speakers from all over the world. What makes it special, however, is that this MOH is also a pre-event for the European Vascular Courses, which will take place just in a few weeks' time in June. My name is Dirk Reuter. I'm the Director of Sales, of International Sales at SIGVARIS AG, and I'm really happy to welcome all of you and look forward to a really nice event. And actually this pre-event of the EVC has some different targets. As a normal MOH, we want to offer you insights from global experts on topics that matter. We also want to give you the possibility to interact with the experts and jointly share the knowledge on a really global scale. We want to give you an idea as well of what you can expect in Maastricht at the coming EVC. I personally am really looking forward to the EVC at Maastricht. Why? The answer is quite easy. First of all, it is a fantastic curriculum and program with a high density of top experts. More than that, you also have the possibility to network and meet friends and colleagues. You can be hands-on and profit from the possibility to participate in various relevant workshops. And on a personal note, it's also one of my favorite towns where I've studied with this special Limburg flair and at a congress venue that is really state of the art. So if you have not yet registered for the EVC, I very warmly recommend you to do so as soon as possible. We hope to meet you in Maastricht very soon. And before we go into the contents of this interesting MOH, I would like to shortly introduce you to Professor Michael Jacobs, who is, now I have a long list, Professor-in-Chief of Vascular Surgery, University Hospital Aachen, Professor-in-Chief of Surgery, Maastricht University Medical Center, Executive Director of Cardiovascular Center, Maastricht University Medical Center, Chairman of the Department of Cardiothoracic Surgery, Maastricht University Medical Center, Fellow of the Royal College of Surgeons of England, and most importantly, founder and organizer of the EVC. Who was starting this amazing educational institution back in 1997 with the very first EVC taking place then in Marseille. So dear Michael, we are pleased to have you here. Would you please just tell us a little bit more about the vision of the EVC and what we can expect from the EVC this year in Maastricht?
Well, thank you very much for your kind words. You can hear me? We have a good connection? Great. Okay. So it's a pleasure on this beautiful sunny Sunday to join you in this session. Thank you for the nice words. And it's great to have this discussion with SIGVARIS, who for the first time is going to be a major partner in our program. Indeed, some 28 years ago, we made a market analysis because in that time already, there were too many meetings, too many conferences. Every week you could go and fly somewhere to join a meeting. And we did an analysis to see what was the desire, the missing link, and that was actually training and training and training. So instead of sitting in a hall and listening to a lecture, there was a big demand for hands-on workshops. So we started that process indeed 25 years ago, small, obviously, everybody starting small, but success proved itself. And now we have been hosting between 2,000 and 2,500 participants every year. And indeed, the message and the goal is to train people with hands-on workshops, also with invited lectures by experts. And we decided to serve 4 main pillars. The first is everything which has to do with arterial. The second biggest one is everything which has to do with venous pathology, diagnostics, and therapeutics. And then we have the third is vascular access, and the fourth is cardiovascular. We developed this whole training program further, and we are very proud to have more than 300 workshops at the upcoming EVC today in 3 weeks as we speak. Today on the 12th of June, we will start. Another interesting part is that the UEMS, which is the European organization where the European examinations are organized, will organize the vascular surgical examinations the day before EVC in Maastricht. So we have this very strong connection with the European organization where all the youngsters perform their examinations. So indeed, we would really like to welcome as many as possible to come to Maastricht. What we see, I have to share that with you. We were at Charing Cross meeting 2 weeks ago. We were at some other meetings. For obvious reasons, people are still a bit reluctant to travel. This has all to do with the situation after the pandemic. Many physicians have to stay home because there are many, many patients who need the care which was not able to be performed during the pandemic. And like I said, there is some reluctancy. So what we see is that in all the conferences in the world now, the number of registrations has dropped significantly. And I expect not to have the 2,000 like we have every year, but at present we have 1,000 participants registered. So I think we will end up like 1,400, 1,500, which is great, coming from 50 different countries. So I'm curious to hear your opinion on this phenomenon. We can see in our systems that the workshops organized by SIGVARIS can still have additional participants. So it would be great if we can spread the news and fill up the workshops. So we are, as an organization, completely happy if the workshop is a fantastic success, and you as a company will have very satisfied participants as well. So that in a nutshell is what we do, and we hope to celebrate the 25th European Vascular Course together with you guys. Thank you very much.
Thank you very much, Michael, for this enthusiastic introduction into the EVC. And I can really confirm what you're saying. I mean, for us also, it's such a nice possibility now to get into contact again with our doctors, physically doing hands-on, because here at the Medical Online Hub, I think we reach hundreds, thousands of people, and it's a nice thing, and we can do a lot for the education. But yeah, sometimes it really just needs hands-on things where we sit together, where we use some of the products, where we have, let's say, patient cases that we discuss, where, let's say, the people are really exchanging very interactively. So really looking forward to this. And having said this, I would like to introduce the first speaker of this afternoon. Dr. Houman Jalaie. He's Associate Professor, Head of the European Venous Center of Aachen-Maastricht. He's a passionate scientist producing many excellent publications and a passionate vascular surgeon. He's a well-renowned and appreciated speaker, having both the overview, but also the ability to go really deep into the matter on topics such as endovenous treatment of post-thrombotic syndrome, endovascular recanalization of chronic venous obstructions, and many more. Having said that, I would say, Houman, let's dive directly into an obstructed vein and tell us what we can expect in there.
Thank you very much, Dirk, for the kind introduction. It's my pleasure to be here, and many thanks for the invitation. So my mentor and Chief Professor Jacobs already explained everything about EVC, so I focus now on my presentation. To be honest, I didn't really know who are exactly the participants, vascular surgeons, phlebologists, IRs. So probably it's a mix of all fields. So therefore, my presentation also is a mix about chronic venous obstruction, how we can diagnose it and treat it. So I think I have 25 minutes and hope I can go through main topics. This is my disclosure. Yeah, very important, of course, in every medical field is to have a perfect anamnesis and clinical approach, and therefore we should know the signs and symptoms of chronic venous obstruction. The chronic venous obstruction is one pathway of PTS, post-thrombotic syndrome. So if we have a DVT, proximal DVT, iliofemoral DVT, and the spontaneous recanalization was not enough, and there are still webs and trabeculations from this thrombosis, there is an outflow problem, outflow obstruction. The outflow obstruction leads to a venous hypertension, and the venous hypertension leads to these signs and symptoms: swelling, tension, heaviness, tiredness, pruritus. But very important, I would like to highlight venous claudication, which is not represented in Villalta and VCSS. It is very important because many of my patients, they come with a sign like this, just a little bit of abdominal collateral. That means on the legs, you see a C0 or C1 regarding the SEEP classification, and they have no big swelling or tension, but they have a severe venous claudication, and they are impaired in their daily life. What is the indication for an invasive therapy? Because again, the conservative therapy is the main pillar of the treatment. So anticoagulation, compression, mobilization is the main pillar. But if we have a patient who is symptomatic and she or he is impaired in her or his daily life, then they could be considered for an invasive treatment. And very important, if there was a DVT and we didn't treat the proximal iliofemoral DVT in the first 2, 3, 4 weeks, then you should go for conservative therapy at least for 10 to 12 months, giving enough chance for the spontaneous recanalization. After 10, 12 months, you can consider the recanalization or the invasive treatment. What is the contraindication? The contraindication is we need a perfect or good, at least a good inflow. If you don't have any inflow from the leg, just consider this angiogram. That was a patient who was referred from north of Germany to us for recanalization because they had recanalized, but the stent, as you can see here, was occluded. But there is no real femoral vein, no real deep femoral vein. So what should you recanalize? The iliac tract? It is probably a perfect intraoperative picture, but there is no drainage from the leg, and the patency rate will be very fair. So DVT in the past 10 months, after DVT, you have to give enough chance for spontaneous recanalization, asymptomatic patients, and contraindication for a therapeutic anticoagulation. Diagnostic tools. The most important diagnostic tool is duplex. Easy, cheap, and non-invasive. But of course, it needs a little bit of experience. If you need further question, and if you are going for indication for a recanalization, then you need a cross-sectional imaging like MRV and CT. In the OR, you need the ascending phlebography, but I highlighted here IVUS, intravascular vascular ultrasound, is mandatory. It is one tool which belongs to a venous center. If you do recanalization, you need the IVUS. And in the post-operative course, you need duplex in special questions, then CT phlebogram or X-ray. That is how our outpatient clinic looks. That is our duplex machine. Very important. Please approach every patient in supine and upright position. Compare both legs, both groins. Okay, we have sometimes bilateral involvement. Visualize the post-thrombotic trabeculation from knee up to infrahepatic IVC. Measure the flow volume, which is prone to error. I know that, but we do it in supine position, and make a precise map. That is a groin of a young lady. You see the post-thrombotic changes in the femoral vein, in the deep femoral vein, and then common femoral vein. In this case, we assume that the inflow from deep femoral vein is somehow enough, and the femoral vein was severely involved. That is how a post-op evaluation in duplex looks. Very easy. You can approach the iliac tract with the stent. You can measure the diameter, the area, the in-stent stenosis. That is the Mytorna point, showing you the dedicated venous stent which has been implanted. And here also a covered, not really covered, because we use non-covered dedicated venous stent, but the stent jailed the great saphenous vein, and you see the flow in the great saphenous vein. That are our venous maps done by our technician who will be in Maastricht, who will be at EVC, and proctored 4 or 5 duplex ultrasound courses. I recommend to you, go to these courses. He's really brilliant. He's doing it with Professor Duanci from Ankara together. These are the venous map which he delivers. Look, chronic venous obstruction of IVC, both iliacs, perfect inflow, also approaching the superficial system. In the next case, chronic venous obstruction, involvement of the femoral vein, involvement of the deep femoral vein and the entire iliac tract left-sided. In this case, that was a patient with 1,000 times of drug injection in his right groin. You see the fibrotic, very short occlusion of the common femoral vein, but luckily the inflow veins were good, so we recanalized this patient. And the measurement of flow. So a precise diagnostic is mandatory. These are pictures of MRVs we received from our radiology ward. You see post-thrombotic changes in the left common femoral vein. Here, a young lady in supine position with severely compared left iliac vein as Turner syndrome. And here you see the collaterals, spontaneous collaterals going from left side to the right side. IVUS. I highlighted already IVUS. IVUS is mandatory, especially mandatory for determination of proximal and distal landing zone while we are recanalizing. So IVUS is important for determination of landing zones. In my eyes, the most important point. And then, of course, sizing. You can use IVUS for better sizing of diameter and length. You can use more and more IVUS in order to reduce the radiation exposure because mainly we are dealing with young patients, less contrast and quality control. Just giving examples for IVUS, that is a patient with typical finding of Turner syndrome, a symptomatic patient. You see also the reflux in the internal iliac vein, and you see this area in which the maximal point of compressions. Then we use the pre-op IVUS, as you can see here, and just have a look now. Now the vein is fully compressed, totally compressed, and that was this area. So believe me, with phlebo, you cannot detect in that sensitive vein. So IVUS is very important. And not only to detect the compression, but also to determine the proximal landing zone. Why? Because we would like to treat the compression. And it is just a question of few millimeters. If you use a long or longer stent, or you just start here, you jail 100% the contralateral non-involved iliac tract. And we know we will have 1 to 4% of contralateral DVT, which we would like to prevent. And if you are too short, you leave the compression and the patient is not treated. So IVUS in combination of a crossover phlebogram is mandatory also in treatment of Turner patients. That is the same patient in post-op IVUS evaluation. That was the compressed area. Now there is a stent with good diameter. So very important, if you look on the literature, you see many of our colleagues, even our group and other groups from the world, compared their patients in acute DVT nivel, which is Turner and other compression patients, and PTS, post-thrombotic. But I give you now just in few slides an impression. So can we really, we assume the gray area is a chronic venous obstruction. Can we compare this patient with this patient? No, we cannot regarding their outcome after treatment because this patient has a perfect inflow. As you can see, deep femoral vein is patent, femoral vein is patent. And if we treat the iliac tract, which is occluded, the patency will be something about 90%. And this is again another patient with PTS. So we put everything together and call them PTS. But this patient has really no inflow. If I can technically, with a success rate of 97% probably recanalize this patient, but the patency rate will be something around 5 10% in long term. So do not compare apples with oranges. Just give you again an example. Stephen Black and Michael Lichtenberg, both good friends of mine, both very well experienced in recanalizing and using dedicated venous stent. And again, they both use the same stent, which is stent, in the same group of patients, PTS. But how does it come that one has 59% patency rate after 12 months and the other 87%? That is a very big difference. And believe me, it is not because the one is bad and the other is very good. Both are very good, but they included different patients with different extension of pathology. So we need a classification which we are now validating, and hopefully soon means next maybe 10 weeks, submitting together with 12 other centers. Now we have data of nearly 1,300 legs. This is group 1, just a nibble. Group 2, the gray areas are not DVT or chronic venous obstruction. Involvement of iliac tract, involvement of iliac tract plus common femoral vein. And then we go to the real extensive disease. The femoral vein is involved in 4B. The deep femoral vein is involved, but femoral vein is patent. And 5 is the really severe group with nearly no inflow. And this is just a preliminary data you see from 824 limbs from 12 centers. As I told you in the last slide, just have a look. The type 5, that means both inflow veins are involved. After 4 years, 5% of patency. And in the literature, we see 80% PTS. So we have to use a classification in order to aid the scientific reporting, comparison of studies and stents, to ease the decision-making for indication and contraindication. If a patient with type 5 chronic venous obstruction comes to me and the complaints is a little bit of swelling and itching, I am not going to make the indication for recanalizing. It doesn't make any sense. But in the type 2, I know I have 90% patency rate. Maybe you can easily make the indication for recanalization. The treatment options, of course, again, conservative treatment is the main pillar, which has been used in all patients. Then we go to the invasive. If needed, we have the open surgical approach, an endovascular approach technique. Believe me, use every time the endovascular technique first, and it will be successful in over 95, 97% of patients. I'm a vascular surgeon and I like open surgery. Therefore, I prepared this movie. I hope it will run. Yes. This is a patient with chronic venous obstruction on the left side. We prepared the common femoral vein left side, and this is the occlusion. And then prepping an exposure of the right iliac tract. And then, so 2 incisions. And then using I think that was a 14 millimeter PTFE external supported in a crossover technique. Then the end to side anastomosis of the end-to-end anastomosis of the left groin. So the left leg is draining here into the bypass, running suture. And then going to the iliac part. So preparing the iliac tract end to side with the PTFE to external iliac vein and finishing the suture, of course, flushing, and that is the procedure. So now the blood is coming from left leg into the right side and creating an AV fistula. So in a patient with left iliac tract occlusion, chronic venous occlusion. So, and the next case, 68-year male patient, PAD, 3 years with PAD. It was performed a below the knee bypass in another hospital, and these pictures are done by the patient. So it's typical, a German patient who documented everything. So the reverse bypass was patent, but the patient developed already 2-3 weeks, already 3 years ago, after the procedure, a below the knee non-healing ulcer wound, and with 5-6 times of revision and a full picture of PTS and severe lymphoria. As you can see, the patient was really helpless. And then one colleague in outpatient clinic setting saw something in the iliac tract and sent the patient to us with a patent below the knee bypass. So it was a chronic venous obstruction, femoral-iliac on the right side. So just compare it with the last procedure which I did. I love an open surgical approach, of course, and this is just vice versa. It was left side occluded, a bypass, now right side recanalization. So I hope I can go very fast. Duplex ultrasound puncturing. This is my colleague, Dr. Babati. He will help me and help us at the venous program at EVC and leading also workshops. That is the initial angiogram. You see the collaterals, you see the occlusion. Then, of course, the video is shortened. We needed 2 hours to recanalize the femoral iliac tract at the right side. We used also a part, the sharp recanalization with the back of a Terumo 0.18. We went into another imaging plane, as you can see in LAO. And then we were luckily successful to recanalize the tract. As you can see, we pre-dilated it. Then we used IVUS to determine the proximal and distal landing zone. We pre-dilated the occlusion, and then we used dedicated venous stents with exact proximal and distal landing zone. And then again, IVUS for the determination of the distal landing zone, because we would like to stop exactly above the ostium of deep femoral vein. And then it was done post-dilation, and that was the angiogram. So the IVUS quality control, you see the nice shape, geometry of the stent, also below the ligament. So in comparison to the open surgical approach, I recommend you to go endovascular. And now just please look exactly above the ostium of deep femoral vein, which is here. The stent ends. Then the angiogram. I don't know why we stopped. So, okay, I show you the angiogram in the next slide. That was before, and that was after recanalization. So exactly the distal landing zone above the deep femoral vein, and the reflux of great saphenous vein is less than before, because now the highway is again free and the blood flow is restored. So that was exactly the IVUS after recanalization and pre-dilation. And just have a look. With IVUS, we could exactly see where the deep femoral main tributary of deep femoral vein is coming. And you see the pre-dilated post-thrombotic changes, and this is the deep femoral vein. And then after it, so you see exactly there the stent ends and the deep above the deep femoral. So IVUS is really mandatory in these cases. This is of this patient, the post-op evaluation, which really is easy: diameter, area, reflux in the great saphenous vein still there, but less, and the flow. That was patient's leg before and just few weeks after the procedure. So just a short notice about endophlebectomy of common femoral vein. In very rare cases, we combine the recanalization and stenting. with the endophlebectomy of the common femoral vein and AV fistula creation as a hybrid procedure only in these cases. This is the class or type 4A. That means post-thrombotic changes goes into the femoral vein in the patient with patent deep femoral vein. But we could compare our endophlebectomy cases with only endovascular in the same patients group, and we saw they have both techniques have the same patency rate, but much more complications in endophlebectomy patients. So please try to stay totally endovascular. So a proper diagnostic approach is mandatory. The common femoral vein and the inflow veins should be approached extensively. That is the most important thing to make the indication. Do not over-diagnose myterna, please, every time in supine and upright position, because in supine position, every young lady might have a myterna. Then, excuse me, main treatment choice is the endovascular approach. Use of IVUS is mandatory, and adequate anticoagulation and compression is also very, very important. So rigid follow-up, especially the 2 weeks follow-up, is very important, because these patients, if they occlude, they have rethrombosis, they might have no big complaints because they have many collaterals. And if they come after 4 weeks or 6 weeks to you, everything is too late. You cannot reopen the occluded tract. So after 2 weeks, you might be able to use local lysis. Thank you very much.
Thank you very much, Houman, for this impressive and very rich presentation. I think it's a very nice example of what you can expect during the European vascular courses. So there will be many presentations and also many workshops. So I think, and you can also see, as diagnostic is really an art, yeah, this is also something that makes sense to be discussed on site, as well as the treatment options. Thank you for that really deep dive into the veins. I would like to ask you a few questions. I think there's one in the chat. And also, before we start with the questions again, I would also like to just tell that there is the EVC registration also in the chat. So the link to the registration can be reached anytime. And please also just be aware that your SIGVARIS partners can also offer you free registrations. So first come, first serve. Just let us know whenever you would like to join the EVC. So now to the question. So I would have one. Houman, I think you made a very good overview also on the diagnostics, preoperative, perioperative, and so on. And I think the diagnostics, they are quite decisive. So on the other hand side, they can also be a huge risk factor, or if there's shortcomings in the diagnostics, this can lead to some troubles. From your experience, where do you see the highest risk factors and let's say the biggest shortcomings in the normal practice regarding the diagnostics?
Yeah, so we have, thank you very much for your kind words. We have to divide between, are we talking now about a patient who already has a chronic venous obstruction, or are we talking about a patient with now acute proximal iliofemoral DVT? Of course, they are totally combined, and a DVT could develop a chronic venous obstruction, but we have really to divide. If I have a patient with a chronic venous obstruction, patients with leg pain, swelling, venous claudication, collaterals, mainly they will be referred to you from phlebologists from all over Germany or some other countries in Europe. Then you know the anamnesis. But please go for a perfect clinical approach and anamnesis. Then you see some collaterals. Then you nearly know what is going on. I would recommend in all patients to go for a perfect duplex with superficial and deep venous system. And believe me, even me, as not an expert like Erwin Thunder, as a duplex expert, you can visualize the post-thrombotic changes even in a very big patient, in the knee area, below the knee, above the knee, and groin. And this is enough to say if there is a good inflow or not. Then if you have question, combine it with a perfect MRV. In my eyes, an MRV is superior to a CTV also because of radiation exposure. And a good radiology ward with a good protocol can deliver you a perfect MRV. There are also patients with not typical signs and symptoms, let us say myterna, which is the danger, and I would to highlight it. You can create in every patient a myterna. In many patients who are thin, young ladies in supine position, just the weight of the duplex probe create a compression. This is not a myterna. So a myterna treatment could lead to a migration of the stent. It should be done by an expert. The approach should be properly combined with the clinical complaints. That is the chronic venous obstruction is not difficult. A real myterna, detected as a real myterna, is very difficult. If you have further questions, go into OR or angio suite, do a phlebo, and then decide for stenting. You should see some small collaterals and reflux in the internal iliac vein, and you should use IVUS.
Thank you very much, Houman. So there's also a lot of questions coming in now from the auditorium. First one is, can we prevent post-thrombotic syndrome and chronic venous obstruction? Which are the aggressive measures to prevent PTS?
Yes, now we have to go to acute DVT because we would like to prevent it. I cannot say we can prevent it, but if we have a patient with a DVT, as soon as possible, in my eyes, or in our regime, in our team, we start with a conservative treatment, which consists of anticoagulation and compression and mobilization, independent if there is an IVC involvement or not. So these three pillars, or the pillar of conservative treatment, is the most important. Then in our regime, again, we know there is an ATTRACT trial, there is a CAVA trial, CAVEN trial, and they couldn't show a big advantage of the interventional treatment. But this trial had a lot of shortcomings. In our eyes, in a young patient with less or no big risk of bleeding, we go in a proximal DVT, in an iliofemoral DVT, for interventional treatment in order to prevent PTS. So combine the conservative with intervention in selected patients.
All right, there's a lot of more questions. I think we can have one or two more, and I think the others maybe we can answer them in the chat, yeah, then afterwards. The last question, in deciding, I cannot read it now, so I can read it. In deciding endophlebectomy, do you prefer a catheter or guide wire passage through the CFV before deciding to the open of the groin?
Yes.
Or any other approach? Often we end up with fibrotic cord on opening the CVF.
No. 100% in this extensive disease, everything should be prepared very well. So you need at least 3-4 hours for a patient. You shouldn't hurry and say, oh, I have 1 hour. Do not go into OR like this. You need a perfect venous map in combination with an MRV. And of course, indications, everything should be clear. Then prep and drep the patient's ipsilateral leg, contralateral leg, and the right jugular vein in every extensive cases. Do not open the groin until you didn't traverse the pathology. It is wrong. So traverse the pathology, which can take 30 minutes or 3 hours with many different techniques. We will show you all of these techniques at EVC with really perfect speakers there. And then decide with a phlebogram plus IVUS if you need an endophlebectomy or not. To be honest, 2012, 2013, I performed maybe 25, 35, or 40 cases of endophlebectomy each year. Now I perform 1 or 2. So prevent endophlebectomy, and it is doable.
Thank you very much for that answer. Yeah, maybe Houman, you can have a look on the 2 other questions and might answer them in written during the event.
I will do my best.
Perfect. Thanks again for this really rich presentation. And with that, I would like to go to our next speaker, Professor Nair Harikrishna. And before I introduce him, I would just tell you something. He was listening very, very carefully, but then actually during the case study, when the wound was shown, I could see a sparkle in his eyes. Because Professor Harikrishna is really passionate about wound treatment. He's the head of Wound Care Unit, Department of International Medicine at the Hospital of Kuala Lumpur. He's professor of the Institute of Health Management, Vienna, Austria. He has the leadership, the scientific leadership at many institutions. He's national advisor of primary health of the Ministry of Health, Malaysia, also advisor for the wound management for the Ministry of Health in Malaysia, RECODA Executive Board, World Union of Wound Healing Societies, and the list goes on and on, chairman of the Asian Wound Council, and various high qualifications as MD at National University of Malaysia, PhD in Medical Science and Wound Management, Fellow of the College Wound Care Specialist since 2017, Initiative Chronic Wounds, and the list goes on and on. But I think we are more interested in the contents, and therefore I would really like to give the stage to you, Nair, and looking really forward.
Thank you very much, Dirk. I hope you can hear me quite well. Thanks to Prof. Jacobs also for inviting us. It's a pleasure to be here. Now, one of the main aspects, basically, when you look at wound management, and even what we call it in the whole world, is looking at venous ulcerations and all that. And I know basically the thing is woundologists, vascular surgeons, orthopedics, plastics, and even general surgeons work together. And one of the things that we actually would like to give you is just a preamble, basically, to a pilot study that we have done. And we will actually allude more during the workshop with the help of SIGVARIS in Maastricht. Now, the talk will be actually on how to simplify venous leg ulcer management with Compreflex adjustable Velcro wrap-on. It's actually what we call this kind of wraps that we're thinking about now, because everyone knows about compression. And I think Hugo Pasch has been talking about compression for ages. And the thing is, it's good to actually have more modalities that we can use to. I work in Kuala Lumpur Hospital. This is the largest tertiary hospital in Southeast Asia with about 2,500 over beds. So we manage about more than 20,000 cases. And venous ulceration is, I think, the second highest number after diabetic foot ulcers. So I will actually go more into the compression part itself. And this is a book that we wrote with Springer, basically looking at compression and chronic wound management. And you can see one of the main causes of your leg ulcers is chronic venous insufficiency. I think what you call it, Prof. Jalaie has already explained about what you call this when you have venous obstruction, what to be done. Now, the thing is, you also need to make sure that you have standard of care, basically. And if you look at venous leg ulcers, there's a failure of the valves in the vein. All right. We talk about the perforators. We talk about basically doing a proper duplex. And we hope that you will be able to see all this basically in Maastricht itself, which is for sure. And if you look at meta-analysis which was done basically, and they actually found that VLU compression is very important because this actually increases the venous leg ulceration healing rates. Now, healing rates are very important, and that's why we have to make sure the standard of care is available, not only in Europe or even in Asia, but even in Africa, South America, Central America, all these places. So we need to actually look at this. And this is what people have been doing all this while, looking at single layer, 2-layer, 4-layer, graduated compression stockings, even compression bandagings, basically. And I mean, in terms of all the other managements. Now, the thing is, we like to add compression wraps up there, because the thing is, we find it's much more easier for people to actually use it. It's easy applicability. So I'll show you some of the things that we actually looked at, because when we looked at the International Working Group for Diabetic Foot, I'm also reviewing the guidelines, which is coming in 2023, together with Dr. Maria Botros from the DFO International. And one of the things that we always look is, we always look at the questions that they ask, and then we assess whether that's sufficient, and then only you do a literature review. So basically, you have to look at evidence-based medicine. David Sackett's basically mentions about that, and how we have to actually have proper evidence, whether it's level 1, level 2, and all that. And then we talk about evidence-based practice. And recently, Shirley Wang and group in 2020 basically talked about real-world evidence, because most clinicians, like you've seen what my colleague has also presented, they like to show you what they call is what they have done. So that's important, because the thing is, you're looking at real evidence and clinical thing. It's not always possible to get a full-fledged randomized trial, which is multicentric or multi-country and double-blinded and all that. So it's a bit more difficult. And this is actually the paper by the World Urology Societies looking at compression venous leg ulcers, a consensus document. Now, MOSTI has also done basically some of the evidences for the effectiveness of inelastic compression wraps. And he found they are much more cheaper and more effective, because the thing is, in compression bandaging, you actually remove it and throw it away. Here, you can actually reuse the wraps. So this is just to show you some of the things even by PASH, which shows that patients are more consistent with this kind of adjustable compression devices. And even Williams in 2017 basically also mentions the same thing. That means it improves their treatment outcomes. Now, compliance, concordance is very, very important. That's why you need to make sure they use it. And now in Asia, the thing is, it's hot, it's humid. All right. So with that, basically, are you going to put compression? How long? And you can't be wearing trousers sometimes if you're wearing a 4-layer compression. So how do they go to work? So that does a lot of problems with them, because talking about static pressure and also dynamic pressure. So you need to make sure they are able to actually ambulate. You can't just put them in the bed. And there's a lot of, as Dirk has mentioned, we talked about X-ray management, talked about the edema basically. So there's a lot of position documents even by UMA and what they call Wounds National, looking at management of X-ray and the role of dressings and even compression itself. So time concept is the other concept which was alluded to in the year 2003 and revisited in 2017 by Caroline Carville and David Leeper. And they've even gone to timers, they've gone to times, looking at surrounding skin and all that. And they have also spoke about time CDST, which is latestly came out in 2017 itself. So one of the things that we looked at basically is look at the wound bed, try to manage that, the edge and the peri-wound skin, and then basically put the patient on the wraps. So one of the other aspect is patient satisfaction. The patient happy with your wraps. I mean, it's no use that we doctors pat ourselves and said, yes, I have done the best thing for them, the best compression, but you must make sure the patient is satisfied. That means in terms of using it, in terms of the application, there is no pain whatsoever, he's able to be mobile. The health-related quality of life has to be good. So that's why we need to assess that. And they looked at the VLUs and with a general assessment, the usability and patient satisfaction, and they found this new compression system is quite good in that sense. Even the quality of life, that means talking about a feeling of well-being, the walking ability, the joy of life, the comfort, they don't feel the itch, they don't feel the heat, they don't feel too much of moisture or irritation, and it's easy to use. So quite a number of studies have actually shown this. And you can even use it with shoes and all that. Now next we move to pain. Now all these aspects I'm touching now is actually what we are actually assessing during the study itself. So when you look at pain, pain is the fifth vital sign. We talk about what we call that pain-free hospitals. We have got many types of neuropathic pain, mixed pain, nociceptive pain. So you want to make sure that the patient doesn't have pain, especially when you put primum non nocere is the first thing when we talk about medicine. That means thou shalt not cause hurt. And that is something which we did when we took the Hippocratic Oath and all that. So therefore, that's why we actually want to see whether, how are the Compreflex wraps? Do they actually cause any pain? Do they alleviate the pain itself? So compression is important. If you look at this, one of the main things that you look at the counterpart ultrasounds is actually to increase the venous outflow. So that is important. And you want to make sure there's no pooling of blood and the venous return is increased and all that. Now, if you look at the compression level of activity, same thing. Whether, when they dawn, they walk, they stand, they climb stairs, they rest and all that. So that is very important when you look at the compression level, because you'll be surprised. When I was in Hamburg, basically, I had a PhD holder who put compression for my leg. And do you know, basically, even with as a PhD holder, he did not reach the pressure they were supposed to be. So that becomes a bit of a problem also. So not all of us are super specialists in that. Now, the ongoing clinical trial that we have started basically in utilizing this Compreflex wraps, it's a quasi-experimental post-market clinical survey. And we have about 100 patients, basically, 25 for each center. The vascular clinics of University Malaya at the National University and also the Islamic University, together with the Kuala Lumpur Hospital Wound Clinic, is actually recruiting these 100 patients. So we will look at week 0, week 1, week 12, week 26. It's a work in progress. And we have a sample size at that time was about 17 at baseline, another 14 were at first week and 6 at 12 weeks. Now the numbers have increased. I'm showing you just a preamble of the actual one, which you will get when you actually come to Maastricht. So it's a good conference to attend and also to learn more things. If you look at the wound surface itself, there is basically a reduction in the wound surface. So that means basically one of the things they look for is the length and the width. So the area assessment is much better. And even here in 12 weeks, you can see there is a reduction in the edema itself. So you bring down the swelling, the circumference is reduced, and also the pain is reduced. You can see patients have actually completely have got no pains when you use the venous straps or the Compreflex straps. And satisfaction is also increased. All right. So therefore, what you call is, it is a good product to actually use. And with this, you can see the breakdown basically at week 12. All right. So you can see basically in terms of the size, in terms of edema, pain, and satisfaction. So these are the ones that I alluded to earlier to show you what we're looking at. And here you can see, you know, at the early stage, the first 12 weeks, the wound looks much better, and there's not much of a depth. Epithelialization is also increased, size is also reduced. All right. And the thing is, what you use for the wound bed is different. You can use different kinds of products. So here, basically, you can even use what we call this ergostart, the tender lipidocolloid, nano-oligosaccharide factors, or other types of dressings that you can actually help in terms of reducing the inflammation, the elevated protease activity, and the matrix metalloproteases. So you can see here, the wound is much better, it's improving. All right. And this is not long. It's only within less than a month, we can see the difference in some of these patients. And here, much more improved. Now, one of the things that we actually have with the compression is not only just to close the wound, but also to actually prevent the recurrence. So following the Compreflex straps and all that, we actually proceed to the stockings on that to prevent that. So I think with that, it's important to show that in the meeting in Maastricht, I will actually show you more cases in the workshop. We also will have an application, basically in terms of how to actually apply the wraps, and you will see yourself first-hand view of how it is easy to use, easy to apply, and the patients, which we yourselves also, we are hoping what we call this, that you will be our model, and you'll be able to actually feel the product itself. So this is something new that's good, and it's always good to add another modality to your armament. With that, thank you very much.
Thank you very much, Nair, for this very good presentation, very rich. And what I really like always is your approach, which is very holistic and which has the patient in focus. On the other hand side, of course, I think it's really interesting, the evidence that you're providing with the newest study regarding the inelastic wraps, because I think this also gives confidence in using inelastic wraps as a treatment method. And I can just confirm we will have this workshop together with you and with Dr. Thomas Noppenay, where we have cases and also have a focus on the application, because I think that's also really important as to the results and the success of a treatment. Having said that, also all the best regards from Dr. Thomas Noppenay, who would also have joined today, but he has an urgency operation that he has to conduct at the clinic at Nuremberg. So I think this is, of course, a good reason not to participate in this meeting. But you will have the possibility to see both Professor Harikrishna and Dr. Noppenay during the workshop of SIGVARIS during the EVC in 3 weeks of time. So I see there's also a lot of questions coming in. So let's see what we're having here. Blood and tibial arteries supplying compression stockings. Do you consider, this is a question of Dr. Mangestati, do you consider angle brachial index, ABI, minimum arterial blood flow in distal tibial arteries before applying compression stockings or compression garments in VLU patients?
Yes, thanks. It's actually very important, because the thing is, if you look at venous leg ulceration, it can be just purely a chronic venous insufficiency, or it could be a mixed picture. So you must do an ankle-based swelling index. And usually when we find that we have even diabetics, basically, I would even proceed to do a TVSI or even a TCPO2, a transcutaneous oximetry, basically, to look at the tissue perfusion. Because the thing is, we have got some cases where the patient complains of pain and we thought it's just more of infection per se. But when you actually assess the flow and all that, you find that there is a mixed picture. They also have got a bit of arterial ischemia. So we have to be more careful. And then the pressure should not be too high. That means it should be controlled according to that. So then we can actually manage it. And if, let's say, and nowadays, I'm not sure how Dr. Jalaie is also finding, I find a lot of cases nowadays are coming in where there's a problem with the tissue perfusion, not so much at the arterial level or even at the what you call venous obstruction per se, but it's just simple capillary perfusion problems. And that becomes a bit more difficult. And then we have to end up with, I mean, we can't do major procedures per se. So I think that is something new we're looking at. So the ABSI is very important. That's the basic to be done.
Okay, yeah, thank you very much, Nair. We also have some more questions, a very pragmatic one as well. How much does it cost? So that's probably a question that I can answer. And this is much less than putting normal bandages. But let's say as to the concrete costs, of course, you have to contact your SIGVARIS partner. So let's have a look on the questions in the other chat. Okay. Let's take this one from Alaldin Saad. My question is, when you have a patient being exhausted after 6 years journey of angioplasty and occluded venous stent and bypass surgery, which improved his venous ulcers, then it reoccurred and occluded. So what is the solution? Any other options to do venous angioplasty and atherectomy, for example? And maybe this is the question also that is, let's say, to the both of you. What would be your approach?
So first, thank you. Many thanks to Professor Harikrishna. Really, it is my pleasure to have you in Maastricht at EVC. Amazing presentation, and I would love to participate at your workshop and to learn. Regarding the question, Dirk, yes. Others than bypass and angioplasty recanalization from the invasive tool, no, you cannot do it, but you can recanalize and chronically occluded stent, yes, in a proper way, of course, with a worse patency than as original without stent, but there are ways to help. And if not, I would say the patient should go really to an expert like Professor Harikrishna to use the best conservative tool. So, Professor Harikrishna.
Thanks, Dr. Jalaie. Actually, what you call this, I completely agree. Because the thing is, if you do not actually go in, you need to actually get a proper center. So the proper vascular center which actually does the recanalization. Because if you don't, what will happen, basically, you might fail. And then there's also a problem like in Malaysia, basically, and even Asia, it's also the funding problem. So they choose cases, basically, which is the best prognosis, which is the best, results per se, and they actually put that. So you need to go to a center which is willing to do all out. And if you were like in basically Charing Cross, some of the, papers that they present actually show these kind of cases, which actually have come in after multiple procedures and all that. Now, it's always good to work together, with Jalaie and also, let's say, people like myself, so we can actually work both ways. That means conservatively also get the compressions going, get the proper dressings per se, because I mean, there's a lot of new advanced products. So conservatively, you can manage both, but you must basically work hand in hand, because I think you need to send to a proper place, like basically in Maastricht, so at least they can, recanalize the thing, and it will heal the wound much, much, much more faster compared to just pharmacopoeia or even basically non-pharmacological methods. Thanks.
Yeah, thank you very much for that answers. Again, as we also have to look on the time, we will go one step further and introduce Dr. Tessari in a few moments. Just also as information, we have now between 350 and 400 active watches on different channels, which is quite positive. And also, very nice comments, like that's amazing work and insightful presentation. Have a great event next month. Said that I can't come due to restrictions. So, I mean, there's some people that would love to come to the EVC that cannot. For all those who can, who don't have to face any more restrictions and can travel to the EVC, I think we will, of course, be very happy to welcome you. Having said that, I would like to introduce to you now a young gentleman from Italy, Dr. Mirko Tessari, who is a university teacher at the University of Ferrara, and he's a tutor in clinical methodology. He's really, really active with his research activity in the vascular diseases and compression therapy. He has a master in hemodynamics of the venous system, doctor in osteopathy, diploma in massage therapy, doctor in physical education and sports, and working at the Faculty of Medicine and Surgery at the University of Ferrara. Mirko is very engaged and in educational topics and has a long experience in the field of compression therapy. He does love to share his experience, his practical experience with various stakeholders. And he will have a workshop together with Dr. Kirill Lobastov, who unfortunately today cannot join because his flight was rescheduled. So he's now sitting on the plane. And but you will be able to meet both Mirko and Kirill then in Maastricht in 3 weeks of time, where they will reflect on the choice of compression, the diagnosis related choice of compression, going through really through all the technologies and thinking through all the contingencies, what you can do good or what can go wrong when using compression. So Mirko, the stage is yours. Looking forward to hearing from you.
Hi, thanks Dirk, and I am sorry for my delay, but I come back to the other congress a few minutes ago. Congratulations to the other authors, the other speaker in this symposium. And see, the elastic compression, the compression therapy is very, very important for the prevention and for the therapeutical stage after a treatment. And but we have a lot of different strategies, different products, and we need to choose the correct device, the correct device compression for our patient. Also, with the correct diagnosis, for the correct therapy, but also for the correct patient for her quality of life. Because if we choose elastic compression and the patient cannot wear the device, he cannot good correct therapy and add evidence for the therapy. So we in the workshop we want to in EVC the course we want to choose the correct compression in base of the other product. So we want to use a different compression device and elastic or inelastic, and make the correct use of this for the patient and for the therapy. But we have many idea during the workshop, and a little surprise for the audience for the course, and we wanted to see in the all in the workshop in Maastricht, and it's a pleasure work together.
So Mirko, thanks for that short introduction of what we can expect during the workshop in Maastricht. I think there were a little bit technical problems, at least on my side. I don't know whether everybody heard everything totally clearly, but I would also just like to sum up. I think what's important in this workshop with Dr. Tessari and Dr. Lobastov, we will really have a focus on practice. On practice, we will have the whole range of garments that are available on the market, not just medical compression stockings, but also inelastic wraps, but also bandages, all of that. And then also have a scientific approach in seeing the pressure that is applied on the surfaces, on the leg, on the patients, on our patients that we're having there, in order to really see the effectiveness of different garment choices. Because on the one hand side, you know, there's the industry that wants to sell some products to you, but on the other hand side, what is most importantly is that the patients get the right products, and this needs evidence, and this needs a discussion, and sometimes it might be a totally different choice than you might be used to. And I think doing this in a very open, scientific and evidence-based way helps all sides to have the right understanding, because in the end, we're doing this all not for the revenue, but we're doing that for the patients, because that's the sustainable approach to make our patients happy. having said this, I think we might end up with a few questions in the channel, in the chat. I will just go back to the open questions. I think there was a problem also in answering them in written. What combination? There's a question to Uma. Thank you so much for your nice presentation. What combination of anticoagulants do you use and how long? Thank you.
So I'm sorry, it was not able to write something in this window. I tried everything. Our normal anticoagulation is rivaroxaban after any recanalization, Materna or type 2, type 3, 4, 5, at least of 6 months. Everything except in exception of the compression, we will go farther to at least 1 year, if not longer or lifelong. Many patients, they had already 2 DVTs, 3 DVTs with pulmonary embolism. They are anyway on lifelong anticoagulation. Very important for us is that we do not stop any anticoagulation before the procedure, even we plan the endophlebectomy or no endophlebectomy, big recanalization. And even if the patient comes to us without any anticoagulation, we start already with DOAC 1 day before the procedure, because in our experience, we had a couple of patients that we had a lack of anticoagulation after the procedure. They are somewhere in recovery 2 hours and go to another ward than our ward, and the nurses are not that familiar, and the lack of anticoagulation led to a rethrombosis. So we are very aggressive with anticoagulation, using mainly DOAC. There is a study running, the ARIVA study, which we belong to it. We are one part of I think 5 hospitals. The PI is Nils Kucher from Zurich. One arm of the patient, prospective randomized, is receiving rivaroxaban, the other one rivaroxaban plus aspirin. And I hope soon, I know one of his team is going to talk about it at Link in Leipzig, and also at EVC we are going to talk about it.
Thank you very much, Uma. There's one more question regarding recurrent leg ulcers that are reluctant to really heal sustainably. So when is skin punch biopsy or skin grafting advised? Did you hear me?
I can hear you. That's amazing words and presenting. I have to see.
It's the second last question.
Yeah. I do not know. Maybe Professor Harikrishna is the expert, or Dr. Tessari in this case. When skin punch biopsy and skin grafting is advised in recurrent leg ulcers, which are reluctant to satisfactory wound healing.
I think I might take that basically. The thing is, if you look at venous leg ulceration, I mean, it's standard of care. Within the first 4 weeks, there should be at least 20% improvement, so that at least you can have a bit of wound closure in terms of the size itself. If you find that basically it is taking a bit much longer, that means it's stagnant, hard to heal wounds or non-healing wound basically, that's one particular reason where you might actually want to check and see whether it's actually a venous leg ulcer or whether it's something else. And in some cases, there's also studies have shown that when you have got chronic ulceration, they can actually also become pre-malignant. I mean, squamous cell carcinoma, basal cell carcinoma has also been founded. And it's not easy to actually get the classical punched out lesion or old ages and all these things, all right? So you might have to need to do a biopsy for that. Now, however, what happened basically, we have, interestingly, we just sent off a patient basically. I mean, we did the skin graft for the patient because that patient was actually having a venous leg ulcer, but there's also a deformity basically at the ankle itself. So it's a bit of what we call valgus deformity. So what happens is this patient has been coming back. It gets smaller, it closes up, and then it breaks down again. It closes up, it breaks down again. And the thing is, there's no invasive procedure for this particular patient at that moment. So what we did, we grafted the patient. So at the moment, it looks much better and good. And the other thing is, do not forget what they call is post-grafting also. Once the wound heals, you have to wear your compression stockings. Now that stockings can be the Ulcer X or what, which is also easy to use, but you have to actually maintain them. And proper, what they call this, care must be there, because these things have been there for many years. I think another case that I had was a patient who had a venous leg ulcer for 38 years. And he's got venous stripping done 3 times. He has got radiofrequency ablation, laser, everything was done. And he still end up, what he call is having the same. Because why? After every single procedure and all these things, compression sometimes is not maintained, not because of the doctor itself, but because the patient. So that concordance, compliance becomes a problem. So if I find any of these things, then yes, I'll proceed to do some. But otherwise, we have done a few cases of grafting, which actually helped.
Mm-hmm. Thank you very much, Nair. So the very last question before we end this this session: what's your opinion in the creation of fistula with iliac and femoral venous stents? It's about long-term patency, which is low after such procedures. However, there is good behavior of dedicated venous stents when put in the innominate and subclavian veins in hemodialysis patients. What do you think?
In my eyes, there is no need for creating an AV fistula if you stay in an endovascular manner. That means nearly all of our cases are endovascular. You recanalize and you put the stent. There is no need. If there is an occlusion, it is because of a very bad inflow and a bad indication. Maintaining the patency with the help of AV fistula doesn't make any sense. You are not improving the leg. You are just playing with showing a technical success, which is not improving the leg. We did it from 2011, 12, 13 to 14, a lot of AV fistulas in wrong patients, even in our classification in group 5. And many of them were patent. After occlusion or closure of the AV fistula, 2 days later, it occluded also, because it was maintained only by AV fistula. That is not a good, I would say, procedure and not a good plan, because we need the drainage of the venous flow from the lower leg, knee area, and upper leg. So AV fistula would help if you do endophlebectomy or open procedure, because you have additional thrombogenicity because of injury of endothelium, and AV fistula would help for 4, 5, 6 weeks. And in that cases, we occlude them very, very fast after 5, 6 weeks. Otherwise, you create another neo-intima hyperplasia and stenosis. So the answer is no.
Okay. So now I have a bad and a good news. So the bad news is we cannot go on with all the questions. The good news is, of course, we will answer all of them. And the other good news is register for the EVC, and surely all of your questions can be answered at Maastricht. Uma, Nair, Mirko, thank you very, very much for participating at this nice event. It's a pre-taste for the EVC, and probably just 0.5% of what you can expect during the EVC when you're on site. So I'm really looking forward to meeting you in Limburg, in Maastricht. As I said, beautiful town, beautiful congress venue, and knowledgeable people around. And I think really a good thing to get back again, travel and see your colleagues and learn together with SIGVARIS group and with beautiful experts from all over the world. Really looking forward to seeing you. Thank you very much, and have a nice Sunday.
Many thanks also to Dr. Tessari for coming to Maastricht.
Bye-bye. Thank you. Bye-bye.
Bye-bye.
Take care. Bye-bye.